52-year-old man, long history of heartburn, now comes with dysphagia. Is it just GERD or can it be something far more dangerous? He also has this reflux symptoms for the last 8 years. He is a chronic smoker with central obesity and takes antacids on and off. He undergoes an endoscopy which reveals salmon-colored mucosa above the gastroesophageal junction, and the biopsy from this mucosa reveals columnar epithelium with goblet cells. What is your diagnosis? Barrett's esophagus. Barrett's esophagus is a specialized gastric or intestinal metaplasia in the distal part of the esophagus where the stratified squamous epithelium is replaced by columnar epithelium with or without goblet cells due to chronic reflux. The risk factors for Barrett's esophagus is that it's commonly seen in men, chronic gastritis, GERD symptoms, individuals who are chronic smokers, individuals with central obesity and in advanced age more than 50 years. Histologically, there are 3 types, that is gastric type which contains chief cell and parietal cells, intestinal type which contains goblet cells, and junctional type which contains mucous cells. Basically, the lower part of the esophagus should not have cells that belong to the stomach or the intestine. Clinical features: the patients may present with typical features of GERD or sometimes hematemesis. On endoscopy, Barrett's esophagus is measured using the Prague C and M classification, where C is the circumferential extent and M is the maximum extent, both from the gastroesophageal junction. Now let us assume that the gastroesophageal junction is at 36 cm. Now, if the circumferential extent is from 33 to 36 cm and the maximal extent is up to 28 cm, then it becomes C3 and M8. C3 because the circumferential extent is to a distance of 3 cm above the gastroesophageal junction, and M8 because the maximum distance is up to 8 cm from the gastroesophageal junction. Why are we doing all this? Because of the dreaded complication of Barrett's esophagus, that is adenocarcinoma of the OG junction. And to avoid missing this complication, we follow the Seattle protocol biopsy, where 4-quadrant biopsy is taken every 2 cm above the gastroesophageal junction. The treatment for Barrett's esophagus is high-dose PPIs. When there is dysplastic Barrett's esophagus without the suspicion of invasive cancer, the epithelium is either resected or ablated. Following resection or ablation, when the new mucosa develops in a non-acidic environment, that is, the patients are given high-dose PPIs, then a neosquamous epithelium is formed. That is, the columnar epithelium now is replaced by squamous epithelium. Barrett's esophagus is also treated with photodynamic therapy, cryotherapy, and radiofrequency ablation. So every patient with GERD is a potential for Barrett's, and every patient with Barrett's is a potential for adenocarcinoma. Next time you see a patient with chronic heartburn, think beyond antacids. To make more such concepts easier, follow the surgical mind.